I'm Steve Tolhurst from Texas Back Institute. I'll just be kind of talking about the advantages of a two-blade retractor that I've been working on. There's my disclosures. In terms of my background, I do a lot of laterals. I've tried a bunch of retractors, and like many people, I started with more of a three-blade design. I went to the Innovasis training course, did a lot of those, liked it. But I had some issues with it. I thought that the retractor was bulky. I really didn't like the table mount. I struggled at times with getting a clean view of the disc. They have those little shims that sometimes you have to put in, and I would find some psoas creep there. And I didn't like the fact that I had to increase the circumferential dilation to get a larger footprint implant in. I really get a 22 in most times and occasionally a 26. And then in terms of how these retractors are fixated to the patient, I noted, at least in my patients, that a lot of times there would be this gradual anterior creep of the retractor. Placing a shim posteriorly was near the lumbar plexus, it's near the foramen. And then when you do your annulotomy, you're cutting toward that. So it can compromise your fixation. And I just found that there were several times where nothing bad happened, but I noticed that my cage was more anterior than where I was at the disc initially with dilators and then with my trials. I think several systems have come out where you anchor to at least one vertebral body just for added stability with even a table-mounted retractor. So I think that concept had some resonance with me. And so what I really wanted was something that would minimize trauma to the psoas and be a less bulky retractor that wouldn't migrate, and importantly, give me really good view of the disc the first time without futzing with it. Allow me to really put the retractor exactly where I wanted. And then I personally like a bulleted tip implant just so I can get into very collapsed disc spaces, especially with scolies. So I looked at a two-blade retractor. I started using the K2 one, actually. It looked different. I really had a lot of questions about it. I worried about it being robust enough, especially with the high crest 4.5 or with the ribs at T12. Had concerns about what protects me anteriorly and posteriorly. And then the fixation pins. I think there's questions about, if you put fixation pins in, are you going to hit the segmentals? Are you going to get a lot of bone bleeding? If you use infuse, is the bone bleeding going to cause, heterotopic ossification that gets into the psoas and causes postoperative problems? And then, when you're trialing, are you going to use your slap hammer and pull out the whole retractor and have a big, bloody mess? So these were my concerns, but I ended up trying it. And, in general, it was a game changer for me. The biggest thing I loved was that I got amazing disc visualization from the outset. With going in along the lines of the psoas fibers and twisting and then dilating, I really got a very good visualization of the disc. The retractor, as it was fixated, wouldn't ever migrate. I didn't have to have a table mount that poked my assistant in the gut. I really found that it was a more of a muscle splitting approach. And I liked the fact that it was, in my mind, fairly atraumatic to the psoas. And then I could really dock it exactly where I wanted to minimize neurologic issues. And also just with this specific thing, as we look at cost consciousness, there's just less disposables with this. And so saved about $1,000, $1,500 a case. Several things I didn't like. I thought that the X-ray visualization around the retractor could have been better. I thought the retractor architecture could have been more open, and I thought the design could have been a bit simpler. So, but at the end of the day, what was a game changer for me was the clean disc prep, no muscle creep. The fact that there were 3 channels in the blade really allowed me to titrate exactly where I wanted that retractor positioned, and really allowed me to put a pin in a safe position. I would just stimulate the pin entry site with the neuromonitoring probe and make sure that it was a safe spot. You can dilate it in a very controlled way. And then I think importantly, it's a 24 millimeter blade. So if the retractor fits, there's no questioning, are we doing an 18 today? Can we get a 22 in? There's really no question of, can we get a 26 in? And the fact that it's kind of open architecture on the front and the back, if you do your initial annulotomy, it's really trivial to just push the psoas anteriorly or posteriorly, take your kerris and do a little bit more of an annulotomy and get yourself a 26 in there if it's possible. And all that from the get-go when you have your retractor put on the disc space. But I thought just much like Netflix is better than what we had, it could be better. So what we developed is a two-blade retractor that has the ability to table mount if the surgeon prefers, or if you need extra stability. I've not had that happen ever with any of the two-blade retractors, but really it gives you maximal radiolucency and a minimal footprint. I went with a C shape, less retractor that can impinge on the crest of the ribs, aluminum blades that are more radiolucent, and a carbon fiber body, which is very irradiolucent, really lets you see where you are on the disc space very clearly. It's kind of some pictures of it there. And then I like the fact that, you can use what you need. If you're really comfortable with a posterior blade, posterior shim, you can convert this to a 3 or 4 blade retractor. But I'd say 1 out of every 10 or 15 cases, the patient coughs or something like that, and you just have all this retroperitoneal fat that pops in, or in a really obese patient, I've put an anterior blade in just to kind of keep the fat out of the way and help me. I've rarely had to convert something to a 4-blade retractor, but it can be helpful, and these are easy things to add on. So in terms of the retractor placement, you go in line with the psoas, and then twist it, as you can see in the last picture, to get in line with the disc. You look, you can look and see with the carbon fiber exactly where you are on the disc space. So you're right where you want to be. Those 3 channels allow you to really, if you want to be more anterior, you can put it in the back channel and push forward. I typically at 4-5 especially will dock very far anterior and twist the retractor to sweep everything back. But you know exactly where you are before you start the case. And again, from this point where you can take additional annulus and additional disc just to get a better fusion rate. This is this in the AP view. Trial sizers go up to 60. Importantly, the way this is designed is the trial actually disconnects and reconnects very easily. One of my frustrations historically has been I always try to look and see where the trial is front to back on the lateral view, and you've got this big, stainless steel thing that gets in your way. So that's the joint there, and then you can see that's the lateral view with the inserter disconnected from the trial, and then you just screw it back on really easily and it comes out. And then, you can see exactly trial cage, or, there's no movement. So just in terms of concerns people have, I've done over 500 levels of these. 4-5 is certainly my most common level. Pin site bleeding hasn't really been an issue for me. I've had to use it bipolar occasionally. I've had to do that with a 3-blade retractor and a table mount as well. Typically some flow seal and a sponge stick with a little bit of compression for about 10 or 15 seconds, which I do with every patient, obviates any concerns. I haven't had the pins pull out during trialing. The trials really don't catch on the blades because they're fixed way down to the vertebral bodies. In terms of retractor strength, that image there is one I did on Tuesday where the pin at 4-5 stimulated at like 3, and I just, it was a big lady and with a big psoas at 4-5, and I just used 1 pin at L4 and were able to get the case done without any issues. So it's strong enough even with 1 pin just to hold things there. No issues with segmental vessel injuries from the pins. And then, the concern of will I cut the psoas or the plexus, the retractor really protects you, and I think one advantage of the direct lateral approach in terms of the vascular injury, which I think is the most catastrophic thing you can have with these cases, and much worse than a femoral nerve palsy, frankly, is, you have a little cuff of psoas in front of you, and that really insulates you from any vascular concerns. But the retractor does protect you. If you need a posterior blade to be more comfortable, then, that's available. I typically use a Fraser tip sucker during my annulotomy just to offer some additional protection. And then I think, as surgeons, we try not to cut bad things, So, you don't cut the iliac on an A-lift. You don't cut the exiting root when you do a T-lift. So, pay attention. I think in conclusion, I was a skeptic of this technology, but it was really a game changer for me. And what I tell people is, if you're thinking about making a change, try it once at L3-4, since that's the easiest level. And I think you'll see that the benefits are really best realized by hands-on experience. Thank you.